Okay, so it seems like everyone's getting settled, so we'll go ahead and start our meeting. If we have not already met, my name is Laura Evans. I'm the State Government Affairs Manager at AAMFT, and my role is to help support advocacy, mainly on the state level, but also working with our grassroots family team, which is all levels of government, state, federal, and provincial. So thank you for coming to the family team meeting. We had some bribes for you for coming, pens and cups passed out by Haley. So if you don't get one, feel free to stop by the family team booth in the exhibit hall. We have more prizes and candy there. So we're gonna go ahead and get started, really kind of explaining the concept of family team, some of the activities we're doing, upcoming activities, and then a legislative update. I wanna make this interactive, so if you have questions, feel free to kind of stop me if I'm on the slide that you're interested in. So first, your AAMFT advocacy staff includes myself and then my boss, the director, Roger Smith. If you could kind of wave to everyone. He handles our federal advocacy, legal efforts for the association, and pretty much everything else. So he has a big plate there. So why is advocacy so important? We are all here because we are interested, or our marriage and family therapist. That's the common thread amongst everyone. And so advocacy is an important kind of core element of associations. We're here to protect and promote the interest of marriage and family therapy. If there was no advocacy, we could be gobbled up by another profession, or no one would know about us, and it just simply wouldn't be sustainable and die out. So it's very important that we have a robust and active advocacy agenda and kind of network so that we can ensure that our profession remains strong. So what is the family team? And I know that's one of the first questions I get a lot. What does that mean? What is the team? So family team stands for Family Therapy, Education, and Advocacy Movement. And those are really two kind of core elements. They're different, but they feed into one another. First, education on what is marriage and family and therapy. Before I got hired, I was like, I didn't know this was a thing. I thought it was just therapy. So we need to do that education component. And then the advocacy component. So what goals are we achieving beyond licensure? Making sure that we're involved in all the programs. Making sure that people and policymakers know about us. That we're at the table when decisions are being made. As some professions and others have found, if you're not at the table when decisions are going to be made, then you're on the table because someone else is there protecting their interest and promoting their interest, which may be directly opposite of ours. So kind of what the family team is and is not. The family team, the idea is to have a well-informed kind of first line of defense, as Tracy mentioned, when there are threats to the profession, and then being able to mobilize and organize when there's an opportunity. So this is the tip of the spear. We know that not all members kind of understand advocacy or want to get involved, so we need a dedicated core who are able to be that first line. And certainly if we can't stop something, then we bring in those other members, strengthen numbers, but we want to be the first line of defense. So with the family, and it's also volunteer driven. So a lot of people think that Roger and I are in our offices in what they call Washington, D.C., but I call Alexandria, Virginia. Big difference, as my commute tells me. And that we're making all the decisions for your state, and we're going to tell you what to do. And that cannot be further from the truth. We are here to support you, but it's really all volunteer driven. I'm not a clinician, I don't know the issues, so I don't know how this affects you, or if it's positive or negative, or what we should do about it. But I can certainly help you organize and be effective in advocating for this change or kind of policy. So it is volunteer driven. We cannot do that alone. We need all of you to coalesce together and help us. What the family team is not. So family team, because it's kind of abstract, people think, well, we'll just call family team and have them come in and have them do this for us and make the calls. We'll say family team, but really it's not an outside SWAT team. It's all of you here organizing and saying, what worked in Alabama? Maybe we can use that in Tennessee. Or can we all work together on a certain issue? So it's really the work that you're putting in. And if you're waiting on someone outside to do the work, then we're just going to keep waiting. So hopefully this will kind of help you understand the importance. Tracy, for those of you at the business meeting, you saw this slide already. This is the current family team distribution. We have about 325 family team members, and you can kind of see where they're distributed throughout the states. There are several states, 7 of them, where there are no family team members. That does not mean work is not being done there. There are certainly advocates. We just need them to learn about family team and join the family team. Sorry, go ahead.
Is there a way to find out who within my state is already signed up or to network amongst people?
Yeah.
I seem to sign up individually and then I find out accidentally, oh, you're on the team.
Yeah, so right now, family team lists are going to division presidents. So division presidents every month receive their membership list and they get their team members because that's membership information, like their email address and address that we don't want to kind of give out to everyone. But there is a family team community, and we'll talk about that a little bit more, where members there's a forum where they can talk to each other and kind of do meetups and find out how other people feel on issues. And it's pretty active forum now, people are in there, so it is active and live. And then this is our Canadian distribution of family team members. As Tracy mentioned, it's a little different there. I'm sorry, go ahead.
No, it's okay. Is there a plan to communicate to members, to AAMFT members about family team other than the annual conference? Because I found that most people I talk to, A, don't know it exists, or B, they say, I signed up for it last year, but I haven't really heard anything. And so there's this buzz around family team over the last conference and this conference, but is there a plan in between the conferences to communicate about its existence and mission?
Yes. So we are targeting family team communications, focusing first on those teams that have, those areas that don't have folks. And sorry, the question was, is there a communications plan around team? And we're certainly doing pushes in all member emails and kind of linking. When there was the TMA lawsuit, we definitely pushed people to, hey, this happened, join team. But right now we're kind of targeting our focus for getting folks in those areas and then helping division leaders understand team so that they can communicate effectively to their members who they probably trust more. Like most people have never met me, haven't emailed with me, but if they hear it from their division leader, then that's more of a trust point and they're willing to sign up. So we are doing multiple strategies and we know that we need to build capacity and awareness. We're just trying to do it more targeted and effective. So some of the team activities we talked about a little bit earlier, there's a monthly newsletter that's released the 3rd Tuesday of every month. And that kind of contains a variety of information from what we're working on the federal level. Like this last newsletter included information or comments that we had submitted to CMS on innovative behavioral health payment models. So that's work that Roger's been doing that we included so that the team knows what we're doing. And then what other divisions may be doing related to advocacy. During the legislative session, which is typically January to July, there's always at least one article on the work that divisions are doing in their state, and then a link to say, if you want to help them on this effort, here's who you need to contact. So that newsletter, and if folks aren't sure if they're on team, if they're not getting that newsletter, then just have them sign up again. We've had 3 webinars so far this year. A 2017 legislative trends, we did that at the beginning of the year to help kind of members and divisions know what we anticipate coming up. And that's information that we get from our meetings in DC with organizations such as the National Conference of State Legislatures, the National Governors Associations. We're taking what they say their members are interested in and kind of feeding that back to you all so you're prepared. So you know that, hey, healthcare, which is typically always a hot topic, is even going to be a hotter topic this year. Or maybe they're focusing on transportation and finance, so it helps plan your advocacy strategy. Of course, we had the Texas Diagnosis Victory, and we partnered with the Texas Association to talk about how that lawsuit affected their advocacy. That was an 8-year lawsuit that we won in February, but how that affected being included in state plans. They were excluded from a loan forgiveness program because the state just wasn't sure if they were going to be around, so they decided not to include them. So it actually affected other areas of their life, and thankfully they were able to get that back in this legislative session, so they are now included in that loan forgiveness program. And our most recent webinar was MFTs and Medicare to tie along with our federal efforts. We had the legislative director for Representative Katko, who sponsored our House bill, and she was on the webinar speaking to members of how you can effectively talk to your members of Congress, meet them in their district offices, and how you can push for that legislation. Yes?
As someone who just joined Family Team today, I don't know any of those webinars. Were that only for people on this, or I don't, where were these webinars?
So these webinars were for team members.
Okay.
It was free. All these webinars are free because team is free. We did put, I think, one kind of advertisement blurb in the therapy news. So if you missed that, then you may have missed this. We also were able to send it to anyone who took action. So if you sent a letter through our advocacy platform to your members of Congress, we knew that you were interested in this issue, so we pushed you out an advertisement for this webinar. So I get a lot of emails. I know you guys get a lot of emails, so we're trying to be targeted to if you're interested in this issue, if you're engaged in team, you've let us know that you're interested in advocacy, so we're going to keep you updated.
Since you just mentioned the emails, I just have to make this huge plea, is we get email fatigue, and your emails don't stand out. So it just they look so much like AAMFT emails, they don't stand out enough. So I wonder if it would be an idea to do a text blast and with the link, so that if people wanted, that would come through their phones, if they could either choose that mobile way to distribute it, to avoid it getting lost in emails. Like my university will oftentimes move it to spam. I don't know if other people's will. So I just worry that so many people have told me they never hear anything, and I wonder if it's because email is not an efficient mechanism for getting it out. So consider text blasting.
Yeah.
Might be an option for you all.
That's a great idea, and if you have any vendors, maybe talk to us after, because I don't know if AAMFT is doing that, but certainly that's something to
Well,
consider.
There's easy ways to set up a group text, so I think you can maybe do that. I don't know how many people are on it, but yeah.
Yeah, well, there's 325 members of team, some of them who may or may not have their phone numbers, but it's certainly something we can consider. We also do social media pushes. We have our advocacy blog. We have different ways of communicating with members. We're really trying to meet them where you are, because we understand, like I said, I get a lot of emails. I'm sure you get a lot. So we try to condense the material and have it in multiple venues so that people can see it. Yes?
Is there going to be a repository where these past webinars would be available to view?
Yes. So all of these webinars, which I think the exception of maybe MFTs and Medicare, are in the Family Team online community. So, which I think is maybe online community with discussion forums. So when you sign up for Family Team, there is one central website that has our events, that has our newsletter archives, that has an advocacy kind of repository where we have the webinars. We have created other visuals, such as a map of where diagnosis is and is not, kind of based on the work that Pennsylvania started. So all of this is in one central location. You sign up and you get access to this community.
Is it like you sign up and then you get an email?
Nope. You go to the webpage. It says sign up. You sign up. It takes about 5 minutes. The webpage refreshes itself and you're in the community.
Okay, I just signed up over at the desk though, as opposed to on the website.
The desk isn't part of our database, so it's going to take, you have to wait till we get home and then upload that because it's a separate system. So you will all get access to the community, and it's fairly easy to use. I don't know if you're in the all-member communities, but it's the same way. We also have our annual conference meeting. There was advocacy information at Leadership Symposium this year, and then we will have a presence next year at Leadership. Our advocacy blog, which is also connected to the AAMFT blog. So if you're at the AAMFT blog, if you click advocacy blog, then you are taken to the advocacy post. We do have podcasts in our community. We did a podcast with the Connecticut division on how to effectively work with a lobbyist. That's a 10-minute podcast that people have actually found really helpful in terms of finding a lobbyist, evaluating a lobbyist, and generally kind of achieving your goals. So these are the team activities that we have currently. This is a wealth of information. I advise you to just check out the community and kind of play around, introduce yourself in the forums, and it's a great way to kind of get started. So then we have upcoming activities. So we have congressional visits planned in support of our federal initiative MFTs and Medicare. And right now we are targeting team members who are in key legislative districts to come out to DC and advocate to their member of Congress. So we've already reached out to the first round of folks who are in those key districts to let them know that this opportunity is available. We plan to have more of that on the federal level going forward. On the state level, it's going to be really up to whatever your division decides to do, either as an interest network or as a family team. Regional trainings. Roger and I will hopefully be going out to certain states and kind of doing an Advocacy 101 training, kind of a introducing team to folks who are interested and kind of explaining the basics. We'll also potentially be partnering with other advocacy trainers to kind of really figure out, based on your strengths, what activities that you could do. And then, as I mentioned, additional state activities kind of based on the needs of your state. Okay, so I'll give it over to Roger.
Thank you very much, Laura. Transition here to federal issues. We'll discuss a little bit. Number one issue, as all of you know, over the last many years has been, for a long time, has been MFTs and Medicare legislation. It's been introduced in both the House and the Senate this year. It's been introduced in the past. It's actually passed both the U.S. House and the U.S. Senate, which is good news in the past. The bad news is it was in different Congresses, meaning, of course, it couldn't go to the President if it didn't pass both chambers of the House, both the House and the Senate. As was mentioned in the business meeting this morning by Tracy, the Mental Health Access Improvement Act of 2017, H.R. 3032, was introduced back in June, late June. We had sent an email blast about that, and many of our members emailed their members of Congress about this. The bill is sponsored by Representative John Katko of New York, and the lead Democrat co-sponsor is Representative Mike Thompson of California. The legislation would add, in brief, MFTs as providers in Medicare Part B program, fee-for-service providers, and also allow MFTs to work in federally qualified health clinics and rural health clinics and throughout the country. The legislation has also been sponsored. There's 23 co-sponsors of this bill right now. We have more co-sponsors at this stage than we did last Congress at this point in terms of the number of months between June 23rd and today, and that number will be increasing. In terms of the Senate bill, it's been less than 2 weeks ago this bill was introduced, the Seniors Mental Health Access Improvement Act of 2017 by Senator John Barrasso of Wyoming. And the lead Democrat co-sponsor of that bill is Senator Debbie Stabenow of Michigan. And we'll be again having more co-sponsors join the Senate bill. The number is usually lower with the Senate than the House because of the fewer number of senators on that particular legislation. And as Laura mentioned, we are going to be having some upcoming activities regarding this legislation, including some targeted Hill visits. Both the House bill has to go through two key committees. The House Energy and Commerce Committee and House Ways and Means Committee, and in the Senate Finance Committee. And so we will be, we've already, Laura earlier this week emailed a few. You may have received a couple of emails about this, most of you have not. Emailing a few members to fly out to Washington in mid-November to meet with their members of Congress on these key committees. Because the way it works, as you're familiar many times in the state level, is you need to really have that key sponsorship on those committees in order to get the bill to the full House or full Senate. So that will be the emphasis. So if you don't receive that or don't receive an invitation, it's probably because your member of Congress is not on the key committee of interest. But we'll keep working on that. We have this, there's one flaw in this email slide. I don't know if anyone recognizes the flaw. It's the number. Actually, it's not a flaw. It's now out of date. We've had about 4,000 emails sent to members of Congress by all of you. So thank you very much for doing that. Thank you very much for both of you for doing that. Or those questions are. It is seniors. You're right. I'm sorry about that. It is seniors. A mistake on that. You found the second error on that. I think maybe we're going to give you a
pen.
Yeah, we have prizes here, yes. Now remember, you may laugh at it, but you know, every dollar needs to be going to the Practice Protection Fund or for advocacy or for what Tracy talked about, as opposed to less on gold-plated pens. So we'll still give you something for that. Yeah, it is. The Seniors Mental Health Access Improvement Act instead of the senators. But they meant the U.S. Senate, I think, is where the confusion came in from on that. And so that'll be one thing. We encourage you, if you haven't already done so, to send email blasts. We'll have continuing ones going out, too, throughout the Congress. And again, the term of the Congress is from the beginning of this year through December of 2018. So these two bills will still be active and live through December of 2018 after the midterm elections. Carl?
Sometimes the bills have included us and counselors. Sometimes it's just been us. These two, who is included?
Excellent question, Carl. We are working jointly with the counselors on this bill, and we have been doing so for several years. We actually work very closely with them at the federal level on this. Our lobbyist, David Conley, is in regular communications. The coalition, explain a little bit, involves, and it's grown over time, it involves AAMFT and also the California Association of Marriage and Family Therapists. And actually they both pay together for our federal lobbyists. So we have a unitary situation. If those of you longtime members might remember that sometimes relations between the two organizations weren't as close as they are now. So we're working in partnership on this issue. Also with counseling, we have three groups, the three main groups, ACA, AMCA, and NBCC. And they each have lobbyists, and so they have their own lobbyists. We have our own involved in that. In addition, and we have sort of a mental health Medicare coalition, informal name they use sometimes. Also, there are some allied groups that are involved. The National Council on Behavioral Health is an ally. They meet with us on this. We've had other groups. We've had prior support from the AARP and others, and some actually standalone clinics, larger institutions have come to us on this as well.
I was just on Monday and Tuesday, the National Council for Behavioral Health Hill Day, and I didn't see any representation from AAMFT. Granted, there were like 400 people there. Does our lobbyist go to those Hill Day events? Because there was a huge representation of counselors.
Generally, our federal lobbyists won't go to another group unless they're invited, and typically they do their own thing. There have been situations where our federal lobbyist has gone or been asked to go with another group, or vice versa. Maybe we've actually had, a lot of times, by the way, there are joint visits when it's lobbyists when two lobbyists are together, and lobbyists from counseling and lobbyists from AAMFT will go together on a visit. Sometimes we get invited to those. One problem, of course, actually, it's one of the reasons the Senate bill, I think, was introduced when it was to catch the National Council.
It was introduced while we were
there.
Yeah,
and it was to dovetail in with that. I'm glad you were there to talk more about it with you after the meeting, how your input was on that.
Yeah.
We've had very good relations with the National Council staff, and these bills are on their agenda.
Right. Yeah, they had excellent fact sheets on both of these bills, and I was appreciative that a majority counselor group was advocating for us on HR 3032. I know they have interest in it as well, but it was nice to collaborate with them on that.
And we're seeing more and more of that collaboration at the federal level among policymakers as well. One more question before I continue. Go ahead.
Sorry.
No, it's fine. Yeah.
Is there a way that we could get access to the fact sheets? Could they be posted on the webpage? Would that be helpful to us to understand what, I mean, I've honestly never read a bill before. I just Googled it, and I know it's here somewhere, but a fact sheet sounds really good.
It does. We actually have a fact sheet, a standalone. It's a more of a general fact sheet on the website, on AAMFT website on Advocacy Medicare. I believe when we sent out alerts on these, both on Facebook and through the family team, there were links to the bills. If you go to, there's also a website if you want to do your own fun research called, I think it's congress.gov, I believe, Laura.
Yeah.
Yes.
I think.
Congress.gov.
Yes.
And you go, you type in the bill number, and 2017, 2018 Congress, and it pulls these two up. And actually, we even have, we check those all the time. Every day I'm on that site because there's usually something new or something else you're worried about with one of the other professions that you're checking out or something healthcare related on that.
So bills change?
Yes, they do. What happens is there's amendments to bills. Also, every time there's a co-sponsor, that's added. That's how we track. Our lobbyist says, when a member of Congress says, I'm going to co-sponsor the bill, his rule is it's not real until it's on congress.gov website, until it's public. You know, when someone says, you know, I'm going to co-sponsor you, it's not real until it's on the public website, when everyone can access it. So that's how we check to confirm someone's a co-sponsor as well. And also they have historical information that we research as well on bills. In terms of other advocacy issues, on that, I guess the key thing is to keep track of this device. Other federal advocacy initiatives, Laura commented briefly. We made some comments recently that the Centers for Medicare and Medicaid Services, they have what's called an Innovation Center. It was formed under the Affordable Care Act. And what the Innovation Center does is it's involved in alternative payment models like accountable care organizations and things like that. They recently had a proposal that came out about starting a behavioral health payment service and delivery model that would involve very integrated health care, medical family therapy model. And it's the way things are going right now. And they want to create something behavioral health centric. And under the rules of the Innovation Center, they can do things that are outside the Medicare Part B parameters, including providers that maybe are not listed under Medicare Part B, such as MFTs. So we went to the hearing, we were sent letters in, we're going to be arguing more about that. We'll be sending some more correspondence to the Innovation Center. We don't know if they're A, going to follow through with a model or not, because they haven't promised, but B, we're going to be hammering away at that, and we'll keep you informed about if there's any need for additional public comment by members or anything like that. But these are the type of opportunities we want to take advantage of when there's new alternative payment models that we can get our foot in the door on something like this. We've also had comments regarding CMS and HHS. This is a new administration. They had some comments about where healthcare should go in the future to combat the opioid crisis and others. We made comments there. We were involved a lot. As you know, you've read the papers. There's been a big push since January to repeal the Affordable Care Act by the Republican majority in the House and Senate. So we've provided comments along with other groups. There was one letter we signed that had 500 other groups. So pretty much almost the entire healthcare universe came out against the Republican-led coalition efforts for varying degrees of severity of opposition by everyone. And that was part of the reason I think these collapsed or they didn't make it to the president's desk so far. There may be attempts later on. By the way, these attempts to repeal, we believe, also caused some delays in the introduction of the Medicare bill because members of Congress are working on this stuff, and it was hard to work on the other health care stuff at the same time. There is a federal provider non-discrimination law under the Affordable Care Act. It's not been interpreted very strongly. We've commented on that as well to HHS and also other changes. Regarding here, not mentioned, wanted to mention briefly VA. As all of you know, the MFTs were allowed into the VA under a federal law in 2006. It only took the VA 4 years, I'm being a little sarcastic here, to implement the regulations, the rules to allow us in. Those rules have some problems. The main one is that anyone who graduated from a non-COAMFT accredited program is ineligible to be an MFT in the VA. Last year there was a law passed to change that. Supposedly there'll be policy guidance coming out maybe as early as this month on this issue. We will see. We're keeping our fingers crossed that it will be pro-MFT and very good, but we're not quite sure yet. But we'll find out on the VA. The VA does not let us or anyone else know in advance what they look like. And we'll let members know about that, of course, when it comes out. Shifting a little bit to some of the 2017 hot legislative topics at the state level. Laura's mentioned some of these already, and some have been discussed if some of you were at the meetings on Thursday. Board consolidation and oversight. There's been an effort in the last 3 years, partly in response to a Supreme Court decision, to try to consolidate, either deregulate professions or consolidate MFT licensure board with others. And even in states like, it was an example in Ohio where they're all MFTs, counselors, and social workers are on one board together. There's been an effort to put them on another big board. And sometimes it's a result of the Supreme Court decision. In most cases, it's just a bare naked attempt to, grab more power for the administrative bureaucracy, or to just weaken licensure boards in general, is what a lot of the proposals are. So AAMFT has been involved with several states in fighting those proposals, and that will keep coming up. There are states that are working on it. There's always a need for reform and improvement, but not for getting rid of boards. Scope of practice is a big issue, of course. We all know about the legal victory in Texas, the 8-year result, where we found out in February that the MFT community won, as we talked about in the business meeting. And also psychological testing, other changes in scope of practice, allowing MFTs to do what they are educated and trained to do. And state law should not be a barrier, artificial barrier to the training that all of you can do in the education. Medicaid inclusion is another large issue that we work on. Private payer reimbursement, associate licensure is a growing issue. It's very important now that associates be licensed and recognized. Even private groups, for instance, the American Red Cross now allows associates to be licensed or to be recognized as disaster mental health providers. That's a new change that occurred in February. We commented actually to the Red Cross and gave them feedback on their proposal, because we're part of a coalition that works with the Red Cross. We don't talk about it all the time. It's part of the advocacy portfolio we work on. However, there is a little caveat. If you're an associate and you're not licensed in your state or have a intern designation, then you can't be a disaster mental health provider with the Red Cross. And it's not really the Red Cross's fault at all. They're a third party. They have no way of knowing. They just want some check from some state entity that you're okay. And that's actually another reason, not even a governmental reason, but a non-governmental reason to try to advocate for some sort of associate licensure at the state level. Loan forgiveness and other things that we're working on collaboratively at the state level. Here's a list of some of our victories and accomplishments just in the last several months. In Alabama is working on getting MFTs, the word diagnosis, into the MFT licensure law. It advanced through one chamber into the second, and they'll be working on that. Louisiana has improved their ability. They can now get rid of some of the oversight on treating clients with serious mental illness. In Montana, that was mentioned at the business meeting, was an outstanding example of success. In Montana, passed licensure in 2009 along with West Virginia. The final two states, West Virginia beat Montana by about 3 or 4 days. So the folks in West Virginia know that you're 49th, they were 50th on the chart. However, they have really nothing but licensure in that state. But this year we went with a very aggressive Do the Practice Protection Fund, and primarily assistance from Laura at the state level and her work and contributions, and also hiring a lobbyist, and critically our volunteer members at the state level. We were able to get 2 major goals passed. The ability to do psychological testing, which social work and counseling have had in that state for the last 8 years. Now MFTs have, and will be added by rule. And also a vendorship law passed effective 2019, which will require Blue Cross Blue Shield of Montana to recognize MFTs, by far the largest payer in that state. So now, instead of having MFT licensure at the very floor, they're now building a platform up and starting to go forward. By the way, we had a 3rd agenda item on there. You think that's pretty ambitious for a state that has under 100 members. We almost got Medicaid passed in that state. Came very close. That would have been this was amazing in itself. That would have really been a trifecta to get all 3 passed in 1 year. New York has been very active. We have a major legislative victory that was announced recently due to our excellent leadership there in the state. Been corresponding with us and working with the New York Attorney General's office, who's very active, and the major Blue Cross Blue Shield plan of central New York that covers most anything outside the metro area and not quite the western part of the state. The big chunk of the middle of the state has now started to recognize MFTs as eligible providers. Significant accomplishment. So thank you for the work that has been done in that state. It's been really effective. And they're doing a lot of other work too, and have some legislation on diagnosis and insurance issues as well. In Texas, they had it's hard to, Montana, Texas, there's so many good victories we had. In Texas, they got included in the loan forgiveness program at the state level that didn't include MFTs. The one I was going to mention more on the top is once a bill was filed in the last few years, last time it was filed in 2017 section, to add diagnosis by statute, to add it to the statutory scope of practice, to add the word diagnosis. And when we got the court, and it wasn't really going anywhere, but once we got the Supreme Court case in, there was a former chief of staff of Obama said, "Never let a crisis go to waste," or something like that. And we got the decision, and what the division did in there is not added diagnosis by statute. So in case the Texas Supreme Court in a few years on an unrelated case sort of went back and said, well, maybe our reasoning or holding in this TMA suit, we'll set that aside. We already have it in statute now. So that it's even more solidification in that state. So that's where it's good for state leaders to be on top of things, and we have a very effective lobbyist in that state who was on top of it, so we were able to get a diagnosis bill through to solidify it in that state. And many other victories that won't comment on, be very, just sort of a summary here. Talk a little bit about the family team state leadership. We're going to be recruiting leaders for the family team. We try to have, if possible, a 2-year commitment. And you'll have a chance to work with other volunteers. Prior experience, by the way, is a division leader is not required. In many states, there's going to be turnover of leadership, so you don't have to be a prior division leader to be involved. And the application will be out soon. It's already been developed, so we'll have that released. And we encourage anyone interested in state leadership to apply for that. We also have some suggested family team roles as well. These are roles that are primarily states-focused, although, again, we're not adverse at all and certainly welcome help even at the federal level on something like that. If you're an expert in, for instance, social media and want to help out on some federal-related advocacy issues, please let Laura and I know. But at the state level, not only being, let's say, the lead in a state, on advocacy, but also being involved in some of these related activities in a special area. And also here's some advocacy support resources as well, staff, peers in the community. We already went over a little bit about the library and the webinar and podcasts. Donating to the Practice Protection Fund, we heard a lot about it at the business meeting, and also some of the grassroots campaign and advocacy engagement. And there's some helpful links that we have in terms of our action alert on Medicare, state advocacy websites, and other useful information. That is it. If anyone had any questions for either Laura or I for the next, I guess we have about 12, 13 minutes or so. We'll be around a little after to talk as well. Feel free.
I've been a Medicare provider for decades in private practice in Indiana because of how our licensure works. We got across the LMFTs, got across first certified in the 93 and then cross licensed in 97 for an additional $52. And I knew that legislatively the LCSW was going to be a ticket to become a Medicare provider. So I continue to do a lot of Medicare work. And I know it's perhaps jumping the gun in a sense okay? But as I approach retirement, you know, one of the things that interests me is that I would like to be able to help other clinicians, like, navigate the crazy, you know, labyrinth that you have to go through to actually, you know, like, you know, everyone's gonna celebrate, you know, a legislative victory. Okay, but I'm just here to say, you know, it could be years before you're gonna be able to get a penny for your services, okay? And because you're gonna call up and they're gonna say, use Form 855A, and then they're gonna reject it, and then it's gonna be C, and then it is just unbelievable. Like, the people who work for Medicare, you know, they work for the government, and, you know, they don't, quite frankly, they just really don't know what they're talking about. So unless you actually have people who have navigated through the system, it is very, very difficult to access the funding. Okay, so at some point, and one of my concerns as being a long-term member since '85, is that there's very, at least I don't know of, and it's always seemed as though there isn't, I don't know how, like, clinicians, especially in private practice, can share this kind of practical, like, nuts and bolts information. Because ultimately, if you can't get paid for your services, okay, then our profession dies. You know, so there are some people who have, you know, survived and have figured out how to do it, but how do we pass that? Well, we have to think about how do we pass that on to the next generation before we're all gone.
That's an excellent question. We've thought a little about it. We haven't put the cart before the horse, but that's something that I think you're telling us is that wait for the hangover after the big party is what you're saying, and that's true. We're aware that, you know, we complain about the VA, and those in the system can know about it, but it's probably nothing compared to what we have to deal with Medicare. I've looked a little bit briefly at some of our competing groups like the NASW, the APA. Those groups actually have some of their staff just specialize in Medicare regulations, like the NASW does. They'll have people who are on staff, and they're sort of in they're within their association, but their job title or their full, you know, 9 to 5 work is dealing with Medicare forms and regulations. Also, both psychology and social work, by the way, have legislation in Congress to make changes to Medicare. You know, social work wants to move up to a higher pay rate. Psychology wants to do some things without restricting. So they want to continue doing that. There's always going to be more work following up. That's something we'll have to give more thought to. I think it's a blessing to have that eventually get to that day, but there'll probably have to be a lot of webinars. We might have meetings or have people like yourself and others who are Medicare providers can talk to everyone about this to educate them. We're hoping there's macro changes to Medicare over time that are an improvement, but we can't wait for that to occur, and that would probably be even 20, 30 years down the road, the way things are going in that respect. Yes, go ahead. Or, yeah.
So I really appreciated that email blast in order to, you know, shoot that quick email to our congressman. That to me is the best thing, because in between sessions, it doesn't take a lot of time to shoot it out. Do you have any information about how much of an impact that makes?
We do. I haven't followed up on the recent ones, but we do give our lobbyists those numbers so we can take on the Hill and say, well, we've had 30 calls or 30 emails to your members of Congress, so we can give them that information. We do get information back on, you know, who responds and things like that through the system, so that gives us an idea. We also have good information on, you know, which districts. I mean, we can tell you that I think we had a list like, you know, at one time in terms of states, it was, you know, Minnesota and California were neck and neck, and Texas. We're sort of on the top 3 or 4. I don't have the list right now.
I was wondering from the legislative aides, does it make a difference for legislators?
It does. It does. They need to hear that when they make a decision on, should I sponsor this bill or not. If it's just a lobbyist it's like the same at the state level. If you go in and meet a member of Congress and please support H.R. 3032, and there's no, oh, we didn't have any emails or calls, then what reason do they support it besides the fact it's a good bill? If they have actual voters, constituents saying we want this, and it's hello, Ms. Stillwell, from Florida, I want this bill, then they're going to be more likely to sign up than otherwise. It doesn't guarantee it. I mean, you can have a member, you see all these high-profile issues, you can get 10,000 calls in. It won't matter to some people. But it matters on a bill like Medicare, where it's not an ideological or a major issue like that, it can make a big impact. Or go ahead. Or who is first, I guess? Okay, go ahead. Oh, yeah, we got a box over here, too, if you need a mic. Can we throw this?
Yeah, you can throw it. So you just throw it to the next person.
Okay.
Have we looked at anything collaboratively with those states like New York that is under the mental health providers? We have, 5 professions that are underneath one bill. Can we collaborate at all with the counselors and with the psychologists? Yeah, I can't even remember. Social workers aren't in our bill.
Correct, yeah.
Yeah, but can we collaborate with them perhaps on Medicare or Medicaid?
That's a good question. Historically, another improvement on the Medicare issue is, well, they have Medicare, and historically, if you go back 15 or 20 years, some of those groups opposed MFTs in Medicare. Now, in recent years, that's changed. There's been no opposition, but there's always a difference between being neutral and supporting. So they have not supported these bills yet, and it's probably unlikely they'll do so, although it's a good idea. We could always reach out to them. We work with them on a lot of other related information like these health reform bills and some general mental health bills, fund SAMHSA more, minority fellowship program. We're in a coalition to preserve funding with them on that issue with those groups, things like that. But typically they, a lot of times, won't support a bill that overtly adds MFTs to a program, just as we may not support adding social workers to a program overtly as a big agenda item. But it's something overtly we can consider on that.
We're supporting something for them, and we're all in it together.
Mm-hmm.
It's giving people a choice. It's
Yeah.
not that you're overloading the system.
Mm-hmm.
I mean, just a crossover in different.
True. Yeah, it's something we can consider doing that too, if they're willing to do that. It'd probably be a good trade. I mean, I think we'd be willing to support their stuff if they would support ours. Thank you. And I guess you had a question, sir?
Yeah, I just had a couple, more practical questions, just to make sure I'm clear with, state lobbyists. So that will now be through the national organization would pay for that rather than where the state divisions have been doing that. But then would they coordinate mostly with that state family team, or how does that play out?
Exactly right. If the state becomes an interest network or family team only, then the lobbyists would be paid for by AAMFT. And if it's a foundational, the contract would be between AAMFT and the lobbyist. And then if it's a foundational goal within that, AAMFT would pay all of that, which is different than the way it is today, where the division assumes all those costs. If it's what's called a secondary goal, which is not Medicaid or vendorship insurance or licensure improvements or threats to the profession, those are the foundational type, in those realm foundational goals. Then usually it would be the reserves of the division, the network, contributions to the network would pay for it. And also we work closely with state leaders. They're essential. We can't cut them out. It's, as you know, many of you have been involved in state work, it's almost impossible for a division lobbyist or a state lobbyist to go in to a legislature and say, support this or oppose it when you don't have advocates out there also writing in or calling or involved, especially on a membership organization issue or a professional issue like this. Independent affiliates, which is the third option, will maintain their incorporated status, and so they will contract directly with the lobbyists. However, even there, the foundational goals will be paid for by AAMFT. Okay. Yes. Robbie?
So, I just wanted to share with the group that we've been working really hard on trying to understand the impact of the variety of communications with both the federal agencies and with legislators. And so I just wanted to share what we've found so far with federal agencies. If you push, sometimes they'll even give you a summary report of all the public comments. So they'll give you a copy, if they did it, and if they have it, of the report of how they summarized all the information, because they do what we do as researchers and take like in vivo and some other things and do all the themes with the electronic comments. With legislators, I think it's important to have all three communications with every single message. And what I mean by that is legislators themselves are very emotional people, and they like a handwritten, small, tiny story letter that's directly to them. They like anecdotes. The legislator staffers like a phone call with three, like a tiny, short 30-second to 1-minute phone call. Hi, this is my name. This is what I support. This is how it affects me. This is the biggest way it affects me. Please consider bringing it up in your meeting. When can you make that conversation happen? And then the electronic, like through AAMFT, a few legislators are starting to use tracking information, but not all of them. But that's really helpful because that massive big data then can say things that sometimes they don't get in other ways. So in my experience and what we are trying to do with every message now is do all three. So.
Thank you very much, Robbie, for that comment.
So
It's good.
social workers we know are really, really good at this, and a lot of the research in the social work literature shows that this is part of their professional identity. And for a lot of MFTs, we don't train them. So this might be, sorry, this is probably a broader AAMFT question, but I just want to ask it anyway. Right now, we're trying to train through this initiative MFTs on advocacy and really get them involved in this grassroots way, which is awesome. But it feels a little reactive. Are there things that we can do sort of as an organization going forward to start training the new generations of MFTs on advocacy to get more of that involvement if we are going to be relying on a national grassroots movement?
That's a good question. Do you have any comments? Go ahead.
So, yes, you're right. I think in the past we have thought as advocacy as just getting licensure, and kind of that was it. We're finding that that isn't enough as we want to move up the ladder. So what we are doing and kind of piloting, working with different divisions in the Leadership Symposium is how can we kind of integrate it? How can we have advocacy mentorship? How can we say a lot of the younger folks, they don't necessarily want to commit to a 2-year kind of leadership role, but they do want to be active on an issue, particularly a social issue. This is my issue, and I'm only going to do stuff around this issue. So what we're trying to do is give them more opportunity to engage and let them know that you are already an advocate. When you go talk to your director, your supervisor, that's advocating. You are a special interest group. When they say, oh, I don't like special issue groups. Well, marriage and family therapy is a special issue. You are a special issue group. So it's just about connecting those dots and bridging those gaps. Unfortunately, we can't, go to the commission and say include this as a requirement to have all students join AAMFT, but we're looking for other ways to show that this is a holistic way of thinking.
So I have a follow-up question on that. Public participation was moved out of the Code of Ethics to the preamble, and I think the message inherent to that is it's not as important as it used to be. Is there a reason for that?
I get a little bit on that. I think the part of the reason is the Code of Ethics, the AAMFT code. One of my duties is also involved in working with our staff attorney, associate counsel Stephanie Frank, on enforcing the AAMFT Code of Ethics. The AAMFT Code of Ethics, unlike maybe some of the other codes, is meant to be enforceable and real, so it's not an aspirational code. So every provision in there is not MFTs ought to do this or ought to do that. It's MFTs do not have sexual relations with their client. It's banned, period. MFTs do not do that, or it may say, yeah, or it may have things, dual relationship should be avoided, you know, and it's on, the burden is on the therapist to do that. Things like that, they're more enforceable. And some of the ones I think that you might be referring to are more, you know, MFTs need to be, you know, like more aspirational or ought to type provisions. And so they were maybe meant more in the preamble where it's more of an aspirational, rather than enforceable. Because the ethics committee really couldn't enforce, oh, well, you didn't vote last fall, you're in violation of the code of ethics. You couldn't go to that extreme or something like that. I think also, in piggybacking on your answer as well, I was going to address the social work one. And they have, one thing is they have a very, hopefully there aren't too many social work, people who are also social workers in the room, I'm talking to a friendly crowd, is they have more, I think, of a guild mentality, and it's percolated from day one when they get into the program, I think, in the MSW program. And we have some programs that are very good, you know, I'm sure in Jennifer's program is, and others that are, hey, you need to join AAMFT, this is a profession. You know, a lot of you probably join as students, and you were told by your professor on day one, you must join this program. And you must sign up for AAMFT, and if you don't, you're not part of the club, or however they phrased it. That may be trailing off, perhaps. I don't know if that emphasis is still there. That's part of it. And there's a lot that AAMFT can't do or mandate that needs to be done overall in the profession, maybe. But social work, I think, has more of that all for one, one for all thing. It harms us in many areas. We can't get hired in some cases in the VA because there's that guild stranglehold of what we've heard in particularly social work, not as much with psychology. And so those are issues that it's more of a, I think you hit the nail on the head. It's broader than just this forum or even AAMFT to address. But I agree there's more of a need for that advocacy push.
I think one of the suggested roles was an advocacy ambassador. And I think that's what we are kind of hoping that members would do. As you learn more about advocacy or team, you kind of encourage that next person to come with me to this meeting, or, you know, this isn't so bad, we can do it together. So certainly kind of peer-to-peer is more effective than staff-to-peer or staff-to-member.
Yeah, your question and then yours, and maybe we'll stop because we're getting a little over time. Go ahead.
Makes us look arrogant. So what are we doing working with other organizations to help them understand that we want to be team players? See what I'm saying?
Yeah, thank you very much. We do work collaboratively at the national level and at the state level with those organizations. There are conflicts that occur. Mostly it's when we try to get in a certain program or add diagnosis to the scope of practice. And you know, in a situation where that occurs, it's usually the peers. Like if you know you work in a clinic with a psychologist and a social worker or a physician, and they don't object to that at all. It's never at the grassroots level. It's usually higher up. And I don't know why that is. It could be that people who rise to the rank of leadership in an association or in those associations are more guild-minded, or let's fight off any attempts at the others. It could be that the others also have a view of themselves as superior, because it's naturally that we would think that you're a systemic therapist because it's the best approach. And social workers may think their approach is the best. It's natural to do that, but you can still work collaboratively while still maintaining your view that, well, we think our approach is more effective, or the research shows it, without denigrating or keeping the others from the ball team.
Two things. One thing is, just a piggyback, is I just one recommendation is I'd like to see, since now AAMFT is moving to more of a national focus, is to do a national lobbying day. I think that would be a great way to mobilize all the states together like social work does. They do a national lobbying day, and then they could come and say, what is the main issue you see that we need to lobby in our state? Because some people need that help, like, here's one that's reachable for you, why don't this be set, you know, we might need some help with that. And then the other is, if we're moving away from the state divisions, with having the lobbyists there, who's gonna be monitoring our state registry? Who's gonna be monitoring the legislations that might be put in that could harm us at the state level?
Yeah, that's a great question. I don't know if everybody heard it. Also, we're overtime, so if you need to leave, I totally understand. So just want to make sure that we're not losing sight that we're losing states. Okay, so a lot of this discussion has been federal, but we spent all of Thursday meeting with the state divisions and then meeting with them individually. So you are not losing a state identity. We are not just focusing on national, but these are national opportunities to participate in. Certainly, you will be hearing more from your state division about what they are deciding to do and what opportunities there are there.
But they're not gonna have a lobbyist anymore, is what
Well,
you're-
that's, so I don't know if anyone was at the business meeting, but as Tracy mentioned, advocacy will be number one. So there will always be advocacy in every state, which is not the case now when there are some divisions where we haven't heard from them for years. Like, we can't find who was the last president, they keep directing us to somebody else. So that's not occurring now. So what will happen is divisions get to choose, and then if they are working on foundational goals, Medicaid, insurance reimbursement, there's a threat to the license, they need to update the license in a major way, then we, AAMFT, are paying for that as a part of your national dues. If you choose to become a part of whatever your division chooses to do, then they will get that money, and then they could use that money to work on secondary goals, such as loan forgiveness, MFTs in schools, kind of those next generation, but we need to make sure every state has those basic 4 components first. So they will have a lobbyist, whether paid from us or them, for those who choose to do that, and that will be taken care of. So they will be monitoring. We also have legislative software that we use to monitor to supplement that. So it's not the primary, but I often send stuff to Pennsylvania of, are you guys aware of this? This came up.
That's good.
And they are
I
often
didn't know
already
that.
aware of it.
Yeah.
So it's just working together.
Yeah, I've never seen that, come out though, that's good though, if you're doing that.
Yeah, we're doing right now because there are division leaders. We're working with the division leaders within the division structure. It's not something that we would send out to all
Oh, okay.
division members to
So
say.
it's just go to
this-
division leaders?
Yes.
And what about that idea for like a lobbying day?
So we are doing that with Family Team. With some of the other associations that do have a national lobby day, their members are paying themselves. They're paying to fly into DC, they're paying for their own hotel.
I meant in your state legislatures, like one day of the year where we all go to our state legislatures and meet.
You mean like a 50 state?
Yeah, yeah, yeah.
Oh, okay.
Oh, so
Yeah.
everyone does it on the same day?
Yes.
Yeah, we could certainly coordinate that. I know several states, California, I think New York did a lobby day where they, as their own state, kind of came together. As we mentioned, some divisions are, I'm sorry? Yeah.
And it's good to do, I think it's good to do when you have like an agenda item, but it's also just good to do
Yeah,
as
it's
a
good
unity practice, and then we go and just remind them who we are, not just be reactive like you were saying earlier, but proactive if your state isn't got any big crisis they're trying to
Exactly.
resolve, so.
So we're helping divisions kind of do that and for
That's great.
kind of identify what's going on, where are you? And in
Right.
divisions where there's no one there, asleep at the wheel, we have to do that.
Absolutely,
Okay.
we appreciate that.
Okay.
Well, thank you very much. I think I'll wind it up since we're a little over time, and please feel free to see us if you have any questions. Thank you very much for participating.